Hello and welcome to part 1 of 3 presentations on the cervical spine. In this first presentation we will do a brief revision of the radiographic anatomy, and then we will focus on the trauma series for cervical spine, the lateral, the AP open mouth and the AP. Here's a quick slide of the lateral. Just take a few minutes, you may wish to pause the video just to make sure you know where the anatomy is on the radiograph. And here's the AP peg view. Again, you may wish to pause the video or just come back to it later if you so wish. And then finally the AP. Again, if you wish to pause the video, feel free. Otherwise, just let it run and come back to it later if you need.
Okay, let's assess the soft tissues. Here we have the trachea, this dense black area. Remember, it's air-filled, hence it's black. So the pre-vertebral soft tissue we're looking at is the space between the trachea posteriorly and the anterior vertebral bodies. And generally speaking, a normal precervical soft tissue is 7 millimeters at C2, so that's about 30% of the vertebral body width, and 22 millimeters at C7, which is about 100% of the vertebral body width. So as long as they're less than that, that's normal. So it's 7 at 2 and 22 at 7. Do you have a nice, relatively smooth shape to your pre-vertebral soft tissue? Okay, let's have a look at these two radiographs. Let's look at the one on the left first. So what was normal? So it's 7 at 2 and it's 22 at 7. We can see with our trachea, this is the posterior aspect of the trachea, the dense black line. So the pre-cervical soft tissue area, it runs between the anterior vertebra and the posterior aspect of the trachea. And we can see there's a large bulging to the pre-vertebral soft tissue region, and that's caused by a fracture to C7, causing this large hemorrhage. So that's what you're looking for hemorrhage in the soft tissues. Now let's look at the one on the right. So here we have our trachea, the posterior aspect of the trachea. So our esophagus runs posterior to the trachea and anterior to the vertebral bodies, and we can see some air trapped within the trachea, and there's a fluid level. So we've got a air fluid level within the soft tissues, indicating that the patient has an obstruction within their esophagus. So that's just something else to be aware of, particularly when you're doing a lateral C-spine to try and see any ingested foreign bodies, such as a fishbone. That's the kind of thing that you're looking for, this air fluid level. And sometimes you may even see a radiopaque fishbone. When assessing for alignment, we use 3 vertebral lines. The anterior vertebral line, the posterior vertebral line, and the spinal lamina line. Now the anterior vertebral line lies posterior to the anterior tubercle of C1, and it lies anterior to the odontoid peg. So the anterior vertebral line lies between the posterior cortex of the anterior tubercle of C1 and the anterior cortex of the dens. So the anterior vertebral line passes between the anterior tubercle of C1 and the dens, which is called the pre-dental space. So the anterior vertebral line runs down the pre-dental space and then down the anterior cortices of the vertebral bodies. The posterior vertebral line runs down the posterior cortices of the vertebrae. The spinal lamina line is the line that forms between the posterior cortex of the laminae and the anterior cortex of the spinous processes. That's the spinal lamina line. Some people run a fourth line down the tips of the spinous processes, but this isn't very helpful because some of the spinous processes lie more posterior than the ones above or below, and it doesn't form a smooth curving line, so it's frequently misconstrued as being abnormal when it's not. A better thing to assess for is the interspinous distance. The interspinous distance is the space between spinous process, between two spinous processes. Diastasis of the interspinous distance can indicate ligamentous disruption or fracture. Okay, so occasionally you may get a slight step in the spinolaminar line at C3. And that's normal, and it's particularly common in children. But the reason why I'm such a big fan of the spinolaminar line is that it's not sensitive to rotation. So therefore, if your patient is rotated, it will not affect the spinolaminar line, particularly at C1, C2. So it's really helpful for assessing for fractures to C1 or C2. So a normal variant is a slight step in the spinolaminar line at C3, particularly in children, but it's not sensitive to rotation. Make the anterior tubercle of C1 your friend. It will be really helpful in aiding you with a diagnosis of any abnormalities, because sometimes it can be very difficult to see the odontoid peg due to overlapping structures. So if you know where your anterior tubercle of C1 is, you know that your peg must lie posterior to the anterior tubercle of C1. And that is absolute fact. The anterior tubercle of C1 will always lie anterior to the peg. So if you're struggling with overlapping structures to identify where your peg is, look for the anterior tubercle. It resembles a coffee bean. So the pre-dentate space, which I've discussed, is the space between the posterior cortex of the anterior tubercle of C1 and the anterior cortex of the peg. The normal pre-dental space in adults is 3 millimeters or less, and 5 millimeters in pediatrics. This radiograph is a good example of how sometimes it can be challenging to see the odontoid peg due to overlapping structures from our mastoid air cells and our occipital condyles. And that's why looking for that coffee bean, the anterior tubercle of C1, is so important, because you know that the peg lies posterior to the anterior tubercle of C1. So what I want you to do for every lateral C-spine is to get into the habit of drawing around the cortices, because if you don't, you'll miss a fracture. So I want you to start off by drawing around the anterior tubercle of C1. The pre-dentate space is, in an adult, 3 millimeters or less, and in a child, 5 millimeters or less. So we have our anterior tubercle of C1 and the pre-dentate space. So if we look at our inferior cortex of the vertebral body of C2, and then we come up our anterior cortex of C2, so that lies posterior to the anterior tubercle of C1, come up over the top of the odontoid peg, down the posterior cortex of C2. Quickly go around our spinous processes, go down our spinal lamina line, just have a quick look at our lamina and our pedicle. All fine. Go down our soft tissue, fine. Okay, I'm now going to draw that in on the next view. Okay, so we've drawn in the prevertebral soft tissue line, the anterior tubercle of C1, the anterior cortex, superior cortex, posterior cortex and inferior cortex of C2, and the spinal lamina line. Now, when we talk about it being difficult to visualise the peg in some views, what can be helpful is that if you know the width of the vertebral body and the inferior aspect of C2, you know that the width of the peg must be of a similar distance, and that width you can calculate posterior to the anterior tubercle of C1. So if you can't see your peg, you can draw in what you think it should probably roughly represent. So let's have a quick look at an abnormal. Okay, here we have a very abnormal cervical spine. But what I want you to do is to find your anterior tubercle of C1, because we know that our odontoid peg must lie posterior to our anterior tubercle of C1. So what I want you to do now is to calculate the width of the vertebral body of C2. So here we can definitely see our anterior cortex of C2, our inferior cortex of C2, and our posterior cortex of C2. So if you draw a line connecting the two cortices to measure the width, you could then use that measurement to position it posterior to the anterior tubercle of C2. So then you can draw in a hypothetical line along the posterior and anterior cortex of the odontoid peg in relation to the supposed width, and at that point you should recognise that there's a marked step in the posterior cortex. There's an anterior step in the anterior cortex. And if we look at our spinal lamina line, we look at our spinal lamina line C1, and it comes down, and we can see it's not connected to the spinal lamina line of C2 or C3. If it was a normal spinal lamina line, you would expect C1 spinal lamina line to lie here. So we have an anterior displacement of C1 onto C2. We can see that the C1 has moved anteriorly in relation to C2. And when we talk about alignment in the cervical spine, we talk about the relationship of the proximal vertebra in relation to the distal vertebra. So the C1 has moved forward in relation to C2. This is called a spondylolisthesis. Spondylolisthesis is when you have forward slip of the vertebra onto the vertebra below. Let's have a look at that with the lines drawn in now. So now we've drawn our lines in. We've drawn in our definite line of our anterior tubercle of C1, of the anterior cortex of the vertebral body of C2, and the inferior and posterior cortex of C2 vertebral body, the definite cortex. So if we take a measurement across the width of the vertebral body, and we use that same approximate distance and position it posterior to the anterior tubercle of C1, and then if we draw in the approximate cortex of the anterior and the posterior cortex of the Dendrite peg using the width of the vertebral body, we can now very clearly see that there is a step in the cortex. And if we look at our spinal lamina line, a clear step, and we can see that C1 has moved anterior in relation to C2, consistent with the spondylolisthesis. And if we look carefully, we can see there's a fracture anteriorly, the fracture line running through the base of the dens. So now we've drawn in that fracture line through the base of the dens, and we can clearly see that C1 has moved anterior to C2. So what is it? It's a fracture. Where is it? A Dendrite peg. How? Spondylolisthesis of C1 onto C2. Here's another cervical spine centered on C1, C2. And I'm going to let you work on this by yourself. I want you to draw in the width of the vertebral body of C2. I want you to find your anterior tubercle of C1, and from that calculate the width of the peg. And then we'll look at this together on the next slide. Okay, hopefully you got something like this, where you could see the distance of or the width of the vertebral body of C2, and then repeated that width posterior to the anterior tubercle of C1, and then you can quite clearly see that there is malalignment of the cortices, so therefore there has to be a problem. We can see that there is a step in the spinal lamina line. So let's look at that again on the next slide. So now we've drawn in the cortex of the anterior tubercle of C1. We've drawn in the entire cortex of the vertebral body C2 and the Dendrite peg, and we can clearly see the step in the spinal lamina line. And we can see that C1 has moved anterior in relation to C2. So there is a spondylolisthesis of C1 onto C2. Would need to be able to see a peg view to ascertain exactly what sort of injury we're looking at. The Harris ring is a ring-like structure due to the projection of the lateral masses of C2 onto the body. Now, as with this particular image, it may appear slightly incomplete inferiorly or superiorly, and that's okay, that's normal. But if there is any disruption to the ring anteriorly or posteriorly, you need to exclude a fracture through the body of C2 or the peg. Let's have a look at that with it drawn in. Okay, here the Harris ring has been drawn in for you. Remember, it's okay if you can't see it inferiorly or superiorly, but if you cannot see the ring anteriorly or posteriorly, then you must exclude a fracture through the base of the dens or the vertebral body of C2. Okay, let's assess this lateral cervical spine. A is adequate. Got the skull base on. 1, 2, 3, 4, 5, 6, 7, T1, even a bit of T2. Yes, this is an adequate cervical spine. S, soft tissues. Let's look at our prevertebral soft tissue line. So it's allowed to be 7 millimeters at 2, which is the equivalent of 30% of the vertebral body width. And it's 22 at 7, which is the equivalent of 100% of the vertebral body width. The prevertebral soft tissue line is normal. A is alignment. So we run down our anterior vertebral line, which runs between the anterior tubercle of C1 and the dens, runs down the anterior vertebral bodies. You may get slight curvature to the vertebral bodies. This is normal. This must not be misconstrued as malalignment. So we have a normal anterior vertebral body line. We run down the posterior cortex of the vertebral bodies. This is normal. We run down our Spinal Lamina line. Now remember, there may be a small offset for C3, which isn't present in this case, and that's normal. This particular patient has a normal Spinal Lamina line. The Spinal Lamina line is not sensitive to rotation. So therefore, this is particularly helpful when assessing C1, C2. B is for bones. You need to go around the cortex of every bone. Round the mandible, anterior tubercle, round the dens, the vertebral body of C2, vertebral body of C3, C4, around the pedicles, particularly of C2, you frequently can get fracture through the pedicle of C2. Around the articular pillars, around the lamina, around the spinous processes, normal. C is for cartilage. Our pre-dental space, normal. Intervertebral disc spaces, our facet joints, normal. This is a normal cervical spine, and that's what you have to do for every single image. You have to adhere to that search strategy, otherwise you will miss fractures. Okay, to refresh your checklist. Adequate. Where's the anterior tubercle of C1? Is it closely sited to the anterior cortex of C2? Are the anterior cortices of the peg and C2 vertebral body aligned? Are the posterior cortices of the peg and the C2 vertebral body aligned? Is there a normal Harris ring? Are the vertebrae intact? Are the lines of alignment normal? Is there soft tissue swelling? So our peg view, which is designed to visualise the odontoid peg and the relationship of the lateral masses of C1 with the lateral borders of C2. So what you want to see is that your maxilla is completely superimposed over your occiput, which it is in this case, so this is perfect positioning. The base of the dens is very clearly visualised. We can make out that the tip of the odontoid process is in alignment, but we can't see if there's a fracture through the tip. But I'll talk about that more when we look at odontoid peg fractures. So we can clearly see the base of the dens very clearly. We want to assess the lateral border masses, the lateral border of the lateral masses of C1 with the lateral border of C2, and they need to be in alignment. The only time where this is an exception is that we don't like to do the odontoid peg view in children under 5, because the lateral borders of C2 ossifies later than the lateral masses of C1. So you get what's referred to as pseudo spread. Pseudo meaning false, false spread. So it appears that the lateral masses have slipped off the lateral border of C2, and this isn't the case. It just hasn't been ossified yet. So the peg view is not helpful in children under 5. We don't assess the relationship of the dens with the medial border of the lateral mass, because you can get asymmetry here due to rotation. So remember, alignment is the lateral mass of C1 in relation to the lateral border of C2. So the lateral mass of C1 with the lateral border of C2. We need to talk about MAC effects, M-A-C-H, MAC effects. MAC effects are created by the overlapping of 2 different densities. And where the 2 different densities meet, it creates a lucent line. So if we look at the image on the left, we can see how where the different greys where they meet, you get an apparent darker line. And this is MAC effect. It's an optical illusion. So we have a lot of problems going on with our peg view. You have lots of overlapping structures. If we look at the image on the right on our peg, we have an apparent lucent line at the base of the dens running into the vertebral body, creating the appearance of an undisplaced fracture. But let's follow that line out. There we go. This is actually the overlapping posterior arch of C1. So the double density of the overlapping arch of C1 with the vertebral body of C2 has created a MAC effect, a false impression of a fracture where there is none. So MAC effects are frequently occurred by the posterior arch of C1, by the incisors, the occiput, and any number of things. So look very carefully to see if it's caused by an overlapping structure. Incidentally, please remove dentures when you do cervical spine x-rays. They create an awful lot of artifact and reduce diagnostic accuracy. So to recap, do the lateral borders of C1 align with the lateral borders of C2? Is there a fracture at the base of the peg? And are the spaces adjacent to the peg approximately equal? Although this can be reduced when there is rotation, and you will have narrowing of one side in comparison to the other. So that's something to be aware of. Our AP view. Let's start off at the bottom. T1, 7, 6, 5, 4, 3. This is an adequate image. It's got everything included. The height of each cervical vertebrae should be equal, approximately equal. Your spinous processes should all be in alignment. The intervertebral disc spaces should be equal, and the space between the sinus processes should be equal. Careful, C5 and C4 spinous processes are frequently bifid, and that's normal. Let's have a look at the spinous processes more carefully. So we can see a normal C7, and we can see that 6 and 5 are adjacent, and suddenly you have a marked space, and suddenly our spinous processes are rotated to the right. The side that the spinous processes are rotated to are the side of injury. So there is an abnormality to the right side causing rotation and malalignment to your spinous processes. And we'll come to what that looks like on the lateral spine in a bit. But in the meantime, always check to make sure that your spinous processes are in alignment. So our checklist are the spinous processes in a straight line. Is the distance between the spinous processes equal? And remember when I told you earlier that if the head is held in flexion, either due to muscle spasm or potentially from how the patient is positioned in a hard collar, this rule does not apply because it can create diastasis to the interspinous distance. Okay, we've reached the end of part 1 of the cervical spine presentation, and I look forward to talking to you again for part 2.